Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. In this slide set, we will discuss eye disorders that cause ptosis. In this set of slides, we will discuss 5 etiologies, namely blepharoptosis, mechanical ptosis, aponeurotic ptosis, myogenic ptosis, and neurogenic ptosis. Blepharoptosis is an abnormal drooping of the eyelid. Unilateral or bilateral ptosis can be congenital from dysgenesis of the levator palpebra superioris or from abnormal insertion of its aponeurosis into the eyelid. Acquired ptosis can develop so gradually that the patient is unaware of the problem. A history of prior trauma, eye surgery, contact lens use, diplopia, systemic symptoms, or a family history of ptosis should be sought. Fluctuating ptosis that worsens late in the day is typical of myasthenia gravis. Ptosis evaluation should focus on evidence for proptosis, eyelid masses or deformities, inflammation, pupil inequality, or limitation of motility. Mechanical ptosis occurs in many elderly patients from stretching and redundancy of eyelid skin and subcutaneous fat known as dermatochalacias. The extra weight of these sagging tissues causes the lid to droop. Enlargement of the eyelid from infection, tumor, trauma, or inflammation also results in ptosis on a purely mechanical basis. Aponeurotic ptosis is an acquired dehiscence or stretching of the aponeurotic tendon, which connects the levator muscle to the tarsal plate of the eyelid. It occurs commonly in older patients, presumably from loss of connective tissue elasticity. Aponeurotic ptosis is also a common sequela of eyelid swelling from infection or blunt trauma to the orbit, cataract surgery, or contact lens use. The causes of myogenic ptosis include myasthenia gravis and a number of rare myopathies that manifest with ptosis. The term chronic progressive external ophthalmoplegia refers to a spectrum of systemic diseases caused by mutations of mitochondrial DNA. As the name implies, the most prominent findings are symmetric, slowly progressive ptosis, and limitation of eye movement. In the current SARE variant, retinal pigmentary changes and abnormalities of cardiac conduction develop. Peripheral muscle biopsy shows characteristic ragged red fibers. Oculopharyngeal dystrophy is a distinct autosomal disease with onset in middle age characterized by ptosis, limited eye movements, and trouble swallowing. Myotonic dystrophy, another autosomal dominant disorder, causes ptosis, ophthalmoparesis, cataract, and pigmentary retinopathy. Patients have muscle wasting, myotonia, frontal balding, and cardiac abnormalities. Neurogenic ptosis results from a lesion affecting the innervation to either of the two muscles that open the eyelids, Mueller's muscle or the levator palpebrae superioris. Examination of the pupils help distinguish these two possibilities. In Horner syndrome, the eye with ptosis has a smaller pupil and the eye movements are full. In an oculomotor nerve palsy, the eye with the ptosis has a larger or a normal pupil. If the pupil is normal but there is limitation of adduction, elevation, and depression, a pupil-sparing oculomotor nerve palsy is likely. Rarely, a lesion affecting the small central subnucleus of the oculomotor complex will cause bilateral ptosis with normal eye movement and pupils. This ends the discussion on ptosis. Next set of slides will discuss disorders that cause diplopia or double vision.